Welcome to the Voices of Healthcare Equity. I'm Kim Tranquata, the founder and CEO of Healthcare Alliance for an Equitable World, and your host on this journey. We are welcoming back Michael Kurliand, the VP of Clinical Quality and Integration at MedWand and adjunct professor of healthcare informatics at University of San Diego's School of Nursing. In our first episode with Michael, he talked about his 25-year career from an EMT to a nurse in the healthcare system, from specializing in pediatrics to geriatrics, his work in emergency psychiatry, and now his work in the startup space with MedWand and the current healthcare system's challenges and where he would like to see the future go, especially for bringing more recognition, more resources, and equity for the geriatric population. Welcome back, Michael.
Thank you. Pleasure to be here.
Pleasure to have you. So we talked a lot about some of the limitations of the current healthcare system, focused on volume, focused on procedures and testing, how the population that you are very passionate about at this stage in your career is vulnerable for unequal access because of issues like transportation, less internet and broadband, being more rural, being economically disadvantaged because of our own lack of training in communicating appropriately with that population, about our lack of education in different learning styles, and lack of specialization in geriatrics. Michael, you have a great background and wealth of information. Where do you see the future? Where do we need to go? And what are the things that are happening and what are the things that still need to happen to bring equity to this group?
Great question. I'm actually optimistic. I think this is going to sound crazy. People are going to be like, no duh, Mike. But I think technology in healthcare, the adoption of it is inevitable. And I'll tell you why. Obviously these last 3-4 years have been a tremendous wake-up call for the healthcare system, not only in the United States, but across the world. But particularly here in the U.S., we recognize louder than ever before the gaps that we had in our healthcare system and just how fragile it was and it is, everything from supply chain to costs. But if I look at some of the most impactful lessons learned from these last 3-4 years is the impact of burnout and burnout on our caregivers. And to me, I look at it two different ways. We have caregivers, like clinicians at hospitals and healthcare systems and clinics, and then we also have caregivers, like I consider the unpaid caregivers, the unsung heroes, like the relatives, the neighbors that are taking care of the older adults. Let's talk about the clinicians first. Even before the pandemic, we had a need for more nurses and more providers of every kind, specialists, primary care docs, and nurses. And depending upon the research paper that you're reading, nurses, you might need anywhere between 300,000 to 1 million. And the point is, as a nurse, I could tell you this much. There were never enough nurses, period. I was always asked to be doing overtime and cover someone else's shift or whatever. There was, no matter what, the numbers are saying, the boots on the ground are going to tell you, listen, there's not enough of us. We're not getting enough health and rest for ourselves, and we're burning ourselves out. So this was before the pandemic. And obviously during the pandemic, we discovered that a lot of folks got extremely burned out, to the point where they had decided that they're going to be done in the next couple of years. And I think what we're seeing now is a response, and rightfully so, by healthcare organizations that they have adjusted their pay scales, but more so they've adjusted how they are onboarding and maintaining their relationships with the clinicians that work for them. Because they invest so much time in onboarding that they're like, hey, how can we make this person's life and quality here as an employee better? Which is great. It's about time, because, you know, the person also invests a lot of time and emotion. What we don't do, and what we haven't figured out yet, is how we take care of the unpaid caregivers. Now, before the pandemic, I think AARP had done some research about unpaid caregivers, and they had discovered that during 2010, for instance, there was about 7-to-1 as a ratio, 7 unpaid caregivers per 1 older adult. So if you had like an elderly mother or grandfather, there were about 7 people in that circle that helped take care of this person on a regular basis. Again, this is research that was done before the pandemic. They found that by 2030, that number is going to drop 4-to-1. That's almost a 50% drop in the amount of people that are kind of taking care of this older adult. Now, I don't know if you've ever had to take care of an older adult. It's hard emotionally, physically, it's time consuming, and they need it. They need people that could help with the care coordination, with the communication between one another, with the physical, with the daily living needs. So technology has to come into play, because there's only 3 things that you have, like 3 levers that you can pull to make things change. You have people, process, and technology. And if you have any less of one of those in the triangle, you have to rely more heavily on the others. So if you have less people, that means your technology and your processes have to improve. And obviously I'm in the telehealth space and the health tech space. Telehealth is a perfect example of technology and process flexibility. And that type of solution is going to start to proliferate more and more, because there's just not enough people.
Yeah, that's terrific. I mean, that is the underlying philosophy behind why our healthcare alliance even exists. 6 million physicians globally, several million nurses, several million OBGYNs, several million dentists, pharmacists, all is shortage globally. And you talk about us having a shortage in the United States. We have the highest density of healthcare workers around the world of most countries, where large parts of the world have a tenth or 100th of what we have. How do you bridge that people gap? That's a people gap. You talked about healthcare organizations increasing pay, but you can pay somebody only so much. They still are going to have to do the work of 2 or 3 people. And one of the things telehealth, in my estimation, can do is help us multiply the people workforce we already have. If we don't hold on to the old philosophy of one employee, one job, and we rethink how we do healthcare and say, hey, really highly trained healthcare workers and specialists. We need to spread you around a little bit. We can do that by telehealth. We can transport you all over the world. We have not yet gotten to the Star Trek point of sending you there, but we almost have, because we have telehealth technology now that are helping doctors guide surgery, that are helping people do ultrasound and transmit those results, that are helping people do a lot of things. So telehealth is a people multiplier at this time as well. What are your thoughts on that?
I completely agree. I think given the right telehealth tools, it can build in efficiencies which allow the clinical team and the caregivers, but let's start with the clinical team first, to practice at their highest level. And what I think the needs are of our current healthcare system across the planet, one is to make sure that we are appropriately using our resources, meaning that I should have my MDs practicing at the highest level. And I should have my nurse practitioners practicing at their highest level. And if there's other duties that can be done by emergency medical technicians or medical assistants, then we should capitalize on that. And I think because there's such a need for maintaining your staff and efficiency, we're going to see more and more of a hard line being drawn as to what certain roles are going to be doing with their time. For instance, I think surgery has done this the best. If I'm a surgeon, I'm in there doing surgery, and the OR has figured out down to the minute how much that OR space is costing and how much all those resources are costing and how much they're making. I think the rest of the clinical world needs to kind of take a page out of their book and say, okay, I'm going to use my surgeon for this, and my surgeon doesn't need to, close things up or open things up. I've never really been in the OR, but I get it. So the surgeon is being used for the exact purpose and their expertise as needed, and other personnel is coming in for the efficiency. And I think we're going to do that. And I think as far as caregivers, when it comes to telehealth, if you could provide them a way where they don't have to leave work or find someone to take care of their kids or pick up their kids while they're taking care of their mom or dad because they have to drive them to the hospital or the clinic for their 15-minute appointment and keep them in the waiting room for another half hour. If we could build some efficiency in for the caregivers, we're going to find more flexibility and access to them as well. So the technology is really, it's almost, it's not almost, you have to have the technology in order to build in the efficiencies. In telehealth, and I remember years ago when I was first in telehealth, I had a lot of providers say, hey, Mike, that sounds like a really nice idea, and pat me on the shoulder. It's like, maybe one day, but not today. And then the pandemic hit. All of a sudden, those same providers are calling me up saying, hey, Mike, how can we do this? And thankfully, we got out of the pandemic, and now folks are really starting to look at how they have implemented telehealth. And they're finding that there is a lot of work that they can do with it, but they want more from it. And you're going to get more and more comprehensive tools and delivery models through telehealth, and you're going to be able to see more complex patients through telehealth. But the world and our providers and our caregivers still need the experience, still need to get the comfort level, and that will take time because it's hard to move the change management needle in healthcare, particularly in the United States.
Michael, you made a really good argument for why the old way of providing medicine only at a hospital or clinic um, was perhaps going to go the way of the dinosaur, and we would need at least a hybridization of that and more going to the patient and going to their home. There are economic, political, and social reasons, as well as healthcare reasons, that is better. Can you talk to us a little bit about how you would sell that? Why is that actually better? And I know why people aren't doing it. Some of that is the money driving what people can and can't do. But let's take that out of the equation. Why is it better?
All right. So, what's the first thing a patient says to their doc once they're admitted to the hospital?
Go home.
When can I go home? Yes. So, right then and there is a really good reason. Like, people are happier at home. And I have to applaud the hospital at home community, um, especially since the pandemic. They've done a tremendous amount of research, and there's a lot of new publications out there that talk about um, the cost savings, but particularly the clinical outcomes are better when you can take care of a patient at home. Now, think about that just for a second. When you go to a hospital, you are in these weird gowns. You're probably sharing a space. There's bacteria that your body is completely unfamiliar with. There's noises and sounds, strangers of all sorts and type coming in and out of your space. There's no privacy. It's hard to rest. And the list goes on and on and on. But if I could be at home in my own PJs with with my pet, like my cat or my dog that soothes me all the time, I understand how the room is laid out. Um, the smells are all my own. I understand the ebbs and flows of just how the sounds are and the colors are when the sun is setting in my house or my apartment or my space. Those are all comfort things, and when you take the patient away from that, you're really disrupting them mentally, emotionally, and physically. So there's a lot of satisfaction that goes into being able to stay in your own space. The other thing from a clinical perspective, and I had recognized this, I'll tell you a quick story. When I lifted one of my first telehealth programs at one of the pediatric hospitals or health systems, was oddly enough nutrition. Now, I was like, why does nutrition care so much? Like, I didn't think it would. Apparently, they had a 30 to 40% cancellation rate for in-person meetings, in-person appointments. And I said, okay, so if we could impact that, because you want to keep your cancellation rate below 10%. But if you're up around 30, 40, something's going on. Now, if your child had a cardiac issue or something else, you're not going to miss that appointment. You're going to show up. You're going to drive however far you need to drive. You're going to be there. But if I got to bring my child in, you're going to tell me that I need to adjust my diet, or you're going to tell me that I'm still overweight, I'm probably going to miss that appointment it's not a must have. I know what you're going to tell me. And again, this is all my assumption as to why they had such a high cancellation rate. So we added telehealth as an option. And all of a sudden, the cancellation rates dropped to around under 10%, which was great. Apparently, like if you don't want to leave the house and like you don't have to obtain all the vitals that you need to obtain as in person, and you're checking up and you're doing a lot of coaching, wonderful. But the thing that the nutritionists quickly were able to do was talk to the patient, and see their environment. And as the dialogue progressed, they were able to say, all right, hey, can we look in your fridge? Let's talk about what you have. So, there's certain, like, they open up their fridge, they see soda, they see high fructose corn syrup type items, they see chips, they see cereal, and they're able to suddenly change, change how they're approaching things. Like, hey, I see that you're eating this cereal. Let's consider this one. It has a lot less sugar, et cetera, et cetera. So you get the idea. So they were able to adjust the dialogue and the dynamic because they were able to see the person in their environment, which is something that they didn't see when the patient came in. Now, when you see a patient come into the office, you might see somebody that got dressed up, that got, that really groomed themselves, something that was maybe atypical for them. You don't see that this person that is always complaining about asthma, when you finally have a telehealth visit, you see that in the background, maybe they have 5 cats walking around and stacks of books and papers everywhere. And you say, okay, so maybe it's a little bit more dusty there. So maybe you can help coach the patient a little bit differently. So it's a different space it's a different kind of interaction when you are seeing into the person's home and living environment rather than coming into your office. So I don't know if I answered the question, but it just it reminded me of how important it is for the clinical team to really understand the patient and their environment. You can't do that when they're coming in.
It's an amazing equalizer, I believe, to go into somebody's home to provide healthcare. Our normal model in the healthcare system really takes a lot of dignity away from the patient. First, they have to leave home and they have to somehow get to you. And then once they get to you, they have to wait for you. And then when they do get into the exam room, they have to strip themselves of all their clothes and all the things that they did to keep themselves warm and comfortable and whatever it is. And oftentimes get into strange positions in uncomfortable places. And then we come in and we talk to them. We examine them and they leave. Whereas when you go into someone's home, like you said, you're in their space. You can see where they live, who they live with, what's in their environment, and they're welcoming you in. It's a very different dynamic than the old dynamic of how we put patients in the position we see them. And I think it's also a situation that can make some of our clinical teams uncomfortable because you have far less control over the patient in their environment outside of your ability to communicate, educate them, and influence them to carry out the things that you want to carry out. It's not like they're in your office where you walk out and you tell the nurse to go in and do X, Y, and Z and draw blood. When they are home, they are in control and you are not in control.
I'm glad you mentioned that. I've heard, particularly the hospital at home clinicians say that the power dynamic shifts a little bit, and it's more of a collegial, let's figure this out together mindset than it is like when they come into the office or the hospital where it's kind of, it's coming from the provider to the patient, and the power is more in the provider side. So when you're going into somebody's home, I think it also, as a provider, it forces you to slow down and really take in all the different aspects of that person's life. And you're really seeing those social determinants of health in real life. It's not just some checkbox on a piece of paper. You're seeing the impact of the quality of care that they're having on their life. you're seeing that bucket or that big bin of medications that might include pill containers from 3 years ago. So you're seeing kind of like what you're contending with in how they manage their chronic disease. Who knows? You might discover that they've had 15 different medications and that they've never really stuck with any one of them in particular, or that they're accidentally mixing things up. But you cannot figure this out until you go into the person's space. Now, not every patient wants that. I get that. And I know not every provider wants that either. But I think the real care, if we want to really make a difference here in the United States, is that we bring care back to the home and understand what's happening at home and focus in on that and shift it from being reflexive care to proactive and preventative care. And I know people say that all the time, but that can't happen by a person just filling out a piece of paper and popping to an office for 15 minutes a pop, maybe twice a year if you're lucky.
And I'm going to say this out loud. I don't want people to think we're just a bunch of bleeding hearts, because we are bleeding hearts and we're proud of that. But we are also economic geniuses, because actually treating the social determinants of health is cheaper than running around in circles, ordering more tests and more procedures, and having the same outcome over and over again. So, this is actually economically the best option as well.
Yeah, and the social determinants of health, I mean, that's not just a health care. It's not just like a hospital or a clinic that has to figure that out. There's issues around housing and the politics around education, income, access to information, access to nutritious food. So it's a multifaceted, complex set of issues that no one type of organization can fix or address. So you ask me, like, how do we, from a policy perspective and from a reimbursement or incentive perspective, I think we're going to need to see more atypical relationships form over the years. I think, for instance, like Meals on Wheels partnering with a healthcare organization or a health insurance provider, more community-based organizations, some turning into like clinics, for instance, not a full-blown clinic, but using the space that's in the community to serve the community, to lower the threshold for access to care. I've heard, and I don't know how and if it's going to happen, but some folks talk about even just using some space in a library as a clinic, a pop-up clinic here and there. I really think that those community-based organizations will have to play a role, and they're probably best suited for it because they understand the community and they're staffed with people that are part of the community. But I also think that retail is going to come into play more and more. I know for the last 5-6 years, everyone's saying about companies like Amazon and Google, they're starting to get into the digital health, the healthcare space. And actually, I've seen some very interesting and optimistic things. That I'll take Amazon and Walgreens, for instance. Those kind of organizations see what's working in the communities and what's not. And I think as they have a very low threshold for what's not working. And once they figure it out, and they are figuring it out because we're seeing minute clinics open up more in certain areas and some close in other areas. And we're seeing the adoption of digital health, especially for employer groups. We're seeing them kind of figure out the reimbursement and the incentive models. And I think entrepreneurial, more advanced healthcare organizations are going to look at them and say, hey, before they take our business or before we're forced to partner with them, we're going to figure this out on our own too. We could take a page out of their book because they've taken some pages out of ours.
We're going to go into the space of anything is possible for 1 minute. And if you could ask for anything, what would you ask for to help make progress on healthcare equity here in the United States in our lifetime?
Okay, this is a good one. I think, and maybe because I've been, I've been around these reimbursement models, and here in the United States, capitalism drives everything. So we have to shift the incentive model, period. And I think these risk-based models will work for healthcare organizations and for payers, but they have to be adopted to the point where they're at least 80% of the reimbursement models. Because when you're in the risk-based kind of a scenario, you're forced to think in kind of this innovative way, like how can we deliver the best care to our population efficiently, effectively, and at the best cost. And so that means we have to make sure that clinical outcomes are good, and that we're taking care of our patients, or else it's going to cost us more money. And as sad as that sounds, that's what drives the business. It's how much they get reimbursed for certain types of care. Right now, if I'm just picking on hospitals, for instance, they maximize profit because they want to. They look for the patients with the best insurance. They want to focus in on surgical patients. They see the more procedures and tests, the more they do, the better, the more they get reimbursed. Shorter stays are much better because they get a certain amount for a stay. So if they get somebody out of that bed and then get somebody else in, they get reimbursed more. And they're trying to figure out how much quickly they could push patients out so they could refill that bed. So hospitals have kind of like figured out like, hey, that's kind of like where we make the most money. We need to just kind of like flip it around. And if they're not focused on risk and they have, then they're going to still stick with that. They're going to still stick with those ways of maximizing their profits that way. I'm okay with you maximizing your profits as long as my outcomes are associated with that. So if my outcomes are poor, your profits are poor or negligible. So I think in my wish list that at least 80% of this country would be at some risk-based model forcing the reimbursement to be based on my outcomes.
Awesome. Michael, how can our audience connect with you and with MedWand?
Sure. Well, if MedWand, it's like med, M-E-D, and like a magic wand, MEDWAND.com. I'm available on LinkedIn, and there's also on the MedWand site. Just go to medwand.com. There's an info at MedWand, but feel free to reach out to me through that, or just type in Mike Kurliand at MedWand, and my email should pop up. I'm happy to connect with anybody that's interested in learning more about my organization, what we do, or just even having more dialogue about healthcare and the healthcare system.
Michael, it's been a pleasure.
Thank you for the opportunity, Kim. It's been a real honor to be here. And I hope folks have gotten something out of this, maybe some new nugget or something to consider. And I like to encourage your audience, if there's anyone that heard anything that I said that, like they have a beef with it, or if they want to like ask me more about it, or if they want to even just, agree with me, I'm happy to hear from them, and I welcome the opportunity to discuss with them as well.
Well, thank you. Thank you for that. Very Philadelphia. You got a beef with me? So let's talk about it.
That is Philadelphia. It is.
Let's talk about it.
You can take the kid out of Philly, but you can't take the Philly out of the kid. Yeah.
And we come full circle to Philadelphia. Well, that ends this episode of Voices of Healthcare Equity. In our podcast today, similar to in our podcast with our international guests, we explored the vital role that collaboration between public and private enterprises and the government for sustainable healthcare equity innovation is so important. As a matter of fact, Michael's final wish is around government regulatory change. With that, I have the ask that if you are a minister of health, a public health officer, or a dedicated public official working to enhance healthcare access and equity, we want your voice on our show. Share your valuable insights and perspectives with our audience. Please contact us at drT@haew.org to secure your spot on the podcast. Listeners, we also need your support. Share today's episode with a friend, leave us a review, share your thoughts, and if you're interested in being a guest, please email us. Visit https://haew.org to learn more. Let's amplify the conversation for a healthier and more equitable world.